So hi everyone, welcome to Access Prescribe once again. Hopefully you're enjoying past discussion which we are uploading. In this team discussion, we are going to talk about osteoarthritis. What is osteoarthritis? How can we approach osteoarthritis? Is it anything changed? Recent evidence? Is it X-rays useful tool to assess osteoarthritis? What are the risk factors of osteoarthritis? Clinical features and so many things in depth. We are going to discuss. This all about our knowledge and our research knowledge and how we practice in our clinical base settings. And most importantly, do we need any passive option for osteoarthritis in current evidence and understanding? Okay, hopefully you enjoy this session as well. Let's start the session. Welcome to Exercise Prescriptor once again.
So start with what is osteoarthritis?
Yeah.
Degeneration of the joint.
Degenerative joint is the current understanding is true.
No, actually, degeneration will occur, but
Okay.
it is not a degenerative disease. We can say like it is not just a degenerative disease. Actually, we can say it is as a systemic disease because of the systemic problem. One of the symptom we are developing as a joint degeneration. That's all. But it is actually starting as a systemic disease.
So how it's become a systemic disease?
So actually it start with an inflammation because as a name implies osteoarthritis. So inflammation has to be happen, right? So first it start with the inflammation. So that is why it is called as a systemic disease. Once the inflammation progress and reaches till the chronic inflammation state, then only it is converted as a joint degenerative disease.
May I know what are the reasons for the inflammation? How the inflammation starts?
So actually there are multiple reasons. Usually we'll say osteoarthritis risk factor or causes like aging, obesity, female gender, repeated injury, right? So this is not only weight bearing or some other. Actually all those causes causing inflammation in our body, it will trigger the inflammatory mediators. For example, if you're having repeated injury in the knee joint, so it will keep on stimulating the inflammatory mediators. So once all the inflammatory mediators is triggered for a long time, so it will be converted as a chronic inflammation. So once it reaches the chronic inflammation, then it will converted as or it will stimulate the synovitis. It will cause inflammation of the synovium, and then gradually it will cause some bone remodeling, cartilage degradation like that. Then only we actually feel the symptoms of osteoarthritis. So once the disease progressed a lot, then only we feel symptoms.
That's why the prevalence of osteoarthritis patients are very asymptomatic.
Yeah.
We can't predict them in a very early stage itself. Once the inflammation reaches to the highest point, when it becomes chronic only, we can
Pain
just
will come. The
yeah.
Pain will come. Then Adam et al. Systematic review, they suggested actually in the people who has osteoarthritis, 43% of people are asymptomatic. 43% of people are asymptomatic because of their previous physical activity, strength, ability was good. They are osteoarthritis, but they are asymptomatic. Joint comparison is not too much. Another factor which is important, which I want to address here, is it X-ray, because so many of us is predicting osteoarthritis following X-ray is predominant determining factor for osteoarthritis. Is it true?
So, X-ray is not a definitive diagnostic tool for diagnosing osteoarthritis because X-ray will not be a reliable source to say whether there is a degeneration or not and all. Because even when the person has degeneration, all the aging people will have degeneration for sure, but they need not have symptomatic changes for osteoarthritis. So that is definitive for osteoarthritis. So when we are going and taking X-ray for two aged people, like above 45 years or 50 years, people might have same changes, but one person might be symptomatic and another person might be
Maybe you're
asymptomatic.
saying here is two people have a same changes in the X-ray, but one person maybe have pain, one person doesn't have a pain. So X-ray is not a definitive tool for understanding the osteoarthritis. Only we can predict if it is severe changes, grade 4, maybe that time we can see some results. But X-ray is not only the. Then how can, so we'll come to that how to diagnose in later part. What about the Kellgren and Lawrence scale? That scale people are used to predict the osteoarthritis. What about that?
So actually, everyone will diagnose with the Kellgren Lawrence scale, but it always says that joint space narrowing or osteophyte formation. Only with that only the scale was formed.
Okay.
But in osteoarthritis, we are having inflammation predominantly. Joint space narrowing and osteophyte formation will be the one of the symptoms, and it will comes in the later stages. But before it start with the inflammation, so patient stiffness, patient's pain, and the inflammation changes, everything will not be predicted with the help of Kellgren and Lawrence scale. It is only based on joint space narrowing and osteophyte formation.
Once the disease severity progress so much,
Ah.
only we can use the Kellgren
Yes.
and Lawrence scale. But when it
Early
com-
OA means we couldn't able to diagnose with X-ray or
always we say na prevention is better than cure. So prevent means, so frequently we are talking about inflammation, right? So now I want to understand, people wants to understand which are all the peoples whose are more prone to get osteoarthritis. Why? We can these 5 peoples, these 10 peoples, this if this is present, what is the risk factor basically for the osteoarthritis?
So the first risk factor is obesity, I think so. So in obesity, the fat deposition will be more specifically. If the fat deposition more, the adipose tissue inside it, it will stimulate, it will release pro-inflammatory mediators. So the inflammation will be high in that case.
Okay, I have a question. The people we can also see lean people with the osteoarthritis,
Yes.
right? What could be the reason for that?
There could be other cause like age, in which the physiological aging matters in that case. It's not only obesity matters and fat deposition matters. There are other risk factors which addresses this issue.
Okay, when it comes to age is also a predominant risk factor compared to obesity. So if the person has obese, there is a 2 reason which he mentioned. Obesity, the person has obesity. If the person has a higher fat mass compared to lean mass, the person could have developed the systemic inflammation, low grade systemic inflammation in the full body throughout the time. That can be one risk factor. And second risk factor is joint loading. Joint loading will be too much, right? The 2 risk factors at the same time for the single person, so that may be the risk factor for developing osteoarthritis in the developmental age. And second risk factor which he mentioned is age. I'm taking that into secondary risk factor.
Yes.
It's the age, because we can't find the people who is 24 years old with osteoarthritis, right? The people who is getting age more and more, we can see the osteoarthritis. When it comes to age is a predominant risk factor for osteoarthritis. What is it tells us? But not every person with the same age, 70-year-old person we can see without osteoarthritis. 40-year-old people we can see with osteoarthritis. So what was the determining factor over there?
Okay, it's not about just biological aging, but it also involves the physiological aging. How are previous physical activity, which was physical activity status? 2 persons who having the same
So sorry to stop you. What was the difference between biological aging and physiological aging?
biological aging is the actual chronological age,
Number
which
which we have. Every year birthday celebration, adding 1 year into your life. That's the biological aging. Fine.
Physiological aging is the amount of physical activity we have done throughout.
Now maybe we can say it in that terminology. Physical capability and organ age, muscles age, skeletal age, cells age, physiology. Your human body. You, for example, you're too fit. Cristiano Ronaldo. Everyone knows the study after he jumped into Juventus. Medical test was taken. They identify as a 25-year-old, but his age is 35. So 10-year younger physiological system was that. If you be physically active, regularly do exercise, you may have age number 50, but you looks like 40. If you're not doing exercise, your age may be 50, you looks like 60. Your movements are like that. You can move faster because age is physiologically determined by your movements are getting slower. So you can't be faster. Your thinking ability will get reduced. Your brain is not function so much. Your muscle can't produce more force. So these are all the things can consider to be you're aging physiologically. Then the physiological age predominant factor means prevention always better than cure again. Again, if you do exercise regularly, be fit yourself, have a good lifestyle, adequate amount of food habit, protein, fibers, plant food, anything. So have everything is good, sleep and everything. Then there is a high chance of those people comes under the 43% of asymptomatic. And in the world, everyone there is a chance of getting osteoarthritis when it comes to that. Everyone will get chance of osteoarthritis. Who is preventing? Who is not preventing? The people who is preventing, they will not end up their life with osteoarthritis. The people who can't prevent it, they will end up their life with the osteoarthritis. Okay, because everyone is going to affect with the inflammation.
Then one more risk factor is that recurrent injury to a particular joint. So whereas if an injury take place in a joint, the inflammation process will be taking place in that particular joint to heal that particular injury.
So we can take this as a third factor.
Yes, third factor.
So first factor is
Obesity.
second factor is
Aging.
Third factor is
Recurrent injury.
injury. Any injury happen inside the joint. Fine,
Yes.
super.
So because of their inflammation, as a secondary osteoarthritis, you may get it. It's a secondary
What are all the
complications.
injuries is potentially lead for that? What are the injuries we can see?
Any specific joint related injuries, ligament injuries,
Ligament,
bursitis.
cartilage, meniscus.
Meniscal injury.
Of course.
ACL injury. Oh, that's the main reason. If
Yeah.
the person have ACL injury or meniscal injury or any other ligament injury inside the knee, there is a high chance of development of osteoarthritis in future.
So if
So
you
that is also preventable and non-preventable. How you are taking care after surgery. That's preventable.
Exactly.
Okay. If any injury happen, it is not that you did surgery or not did surgery. How you are taking care is more important because both surgical is that
I have a doubt.
Yeah.
Now I have a doubt because after ACL injury or meniscal injury, people fear that without surgery they get osteoarthritis. So is this a myth or?
Yeah, that's what I want to try here. Add here. Both surgical. There was a research evidence. 20-year follow-up research evidence says that, and the people who did surgery, who did not do surgery, after 20 years of follow-up, everything is same. It is not like if you didn't do surgery, you will get osteoarthritis. It is not like if you do surgery, you will not get osteoarthritis. It's all about after surgery or after injury, first of all. Consider to be after injury, how you taken care of that leg, how you taken care of the body, how you taking care of your inflammatory process.
Yes,
in
how
the human
physically
body,
active
physically
you are.
active. So any other points to add here? 3 points we discussed. The risk factor.
About the inflammation, I would like to know. So about the inflammation, why the injuries occurring near the joint or close to the joint area is more prone to get OA in the future, na? It is because of the inflammation process occurring there. Whenever we get an injury, to repair the injured structure, inflammation will be occurring as a normal physiological mechanism. But when the inflammation usually subsides after the healing process has occurred. But if the inflammation persists, so on, it usually occurs when we have physical inactivity or obesity might trigger the prolonged or persistent inflammatory process. At that time, it might be harmful that it will also promote or make the person prone for getting osteoarthritis in the future. So that is why whether with surgery or without surgery, the inflammation is persisting and making the person prone for getting osteoarthritis in the future.
So frequently we are talking about inflammation. How that inflammation occurring? How to prevent that inflammation?
Yeah, about that, there are a lot of factors which can cause chronic low-grade inflammation in the body. So chronic low-grade inflammation is nothing but inflammation which is not obviously seen. Any signs of inflammation will not be seen apparently. So it will be like a silent killer inside our body. It will be persistent, but it will not be showing any obvious symptoms outside the body.
So if you ask what is low grade inflammation means, how we will test it is, so we can take some blood test. So at this point, low grade inflammation.
Exactly blood test.
Yeah, and that point of low grade inflammation.
No, what exactly we test in blood test?
Okay, erythrocyte sedimentation rate
ESR,
and
CRP,
C-reactive protein. Yeah.
Tumor necrotizing factor. Okay, these are all the things. We
So in that point of low grade inflammation stage, the values will be increased, but the symptoms will not be occurring at that time. So that is called low grade inflammation. So when it became chronic only, you will be feeling the symptoms.
If anyone is taking a blood profile, ESR, either ESR, CRP, anything is higher, the person, there is a risk of getting osteoarthritis higher than the people who have a normal value of this inflammatory process. So what was the reason for having a higher inflammatory process, low grade inflammation? For example, higher than the normal value for a certain period of time, either CRP, ESR, TNF, alpha, IL, interleukin 6, 8, or anything. So what was the reason for elevating these values?
As Silekya mentioned, obesity and physical inactivity both are a very major trigger for developing low grade inflammation, because she mentioned it already, but still when we have obesity and the person is having a lot of fat in the body, fat cells will release a substance called adipokines. So adipokines have various functions also, but there are some adipokines which are capable of triggering the inflammatory process. So this is where the chronic low grade inflammation starts. So obesity is not only a risk factor for osteoarthritis. A lot of things happen because of obesity. We have obesity as a risk factor for diabetes, hypertension, cardiovascular disease, everything else.
And also diabetes and hypertension also risk factor for osteoarthritis.
Yes.
Yeah.
Because diabetes also will cause stimulate the inflammation
So anything,
constantly.
Exactly. Anything is increasing your inflammation, that is the
Cause.
risk factor for all the kind of disease.
Yes.
Osteoarthritis also.
And it's like a vicious cycle. One triggers another, another triggers the same thing. So the inflammation will go on and on and on if we do not control it. So as chronic inflammation, low grade inflammation is not very apparent to obviously visible, so we might not know it is occurring in the background, so we might not look into it to solve it.
Exactly. So to know more about it, we have to go deeper physiological signs, that oxidative stress, free radicals, and so many things, as someone trying to mention. So if we talk about that, people will don't watch this video, they'll cut and they'll move to another aspect. So we stick with osteoarthritis. Deep physiology also helps. This is what we are studying physiology.
Yeah, right.
Right.
So if
So
we
much
understand
things
the
are
deep
there.
physiology, it helps more in understanding the osteoarthritis and giving the expectation to the patient
Exactly.
matters.
Not only osteoarthritis.
Yes.
Any condition.
In any condition.
You can say it that way. So in that point, to reduce inflammation, what some person has to do?
Yeah, here a beautiful thing about exercise is whenever we do exercise, whenever a muscle contraction occurs, there is a release of myokines. As adipose tissue releases adipokines, muscle tissue releases myokines. Myokines, on the other hand, has a lot of functions, a metabolic function and inflammatory function too. But some of the myokines released from the muscle contraction has anti-inflammatory properties. So they are anti-inflammatory myokines like interleukin 6, interleukin 10, interleukin 15. All those released by the muscle are anti-inflammatory in nature. So they will go and check the low grade inflammation happening in the body, and it will be helping us in the background. We might think exercise is going to help us strengthen our muscles or preserve the muscle strength we have, joint mobility we have, but actual process going on is it is helping you in the background, in the deep physiology happening.
Again,
Exercise. In the deeper science, it is helping it in various other ways also. So a simple muscle contraction is helping us in that way.
And one more thing, if you do exercise or if you move your body, it will release cortisol. That is an anti-inflammatory hormone. It has anti-inflammatory properties too, cortisol. So that will also fight against the inflammation. Okay.
That beautiful points, but I have counteracting another question which commonly the people who's watching video have. So the problem with osteoarthritis, unable to do exercise, but exercise have a lot of helps. So we'll come to that point. What I'm trying to hear, don't worry, we will discuss that also. But rather deviating so much, with 3 risk factor we discussed, and we discussed about inflammation and something as well. Then we'll move to the any other risk factors you want to add or mention.
Yeah, one more risk factor is too much of loading. The joint is
Okay.
also overuse of the joint
Overuse
is also a
of the
risk
joint.
factor. For example, a marathon runner who is running continuously for an average of 30 miles per week, because their
30 to 50 miles per week.
30 miles per week, approximately 50 to 60 kilometers
Kilometers. Okay.
per week they will be continuously loading the joint. But according to a recent research paper, what they have mentioned is marathon runners get osteoarthritis, but not
As high as sedentary population. Sedentary population get osteoarthritis 13.6%, compared to osteoarthritis gets by the marathon runner 8.6 something 8.6%. And recreational runners is too low. Recreational runners too. It's not like you should not run tomorrow for 5 kilometer. So you can run recreationally. When it comes to marathon runner, see 30 mile per week is a 58 kilometer per week. 58 kilometer definitely you won't run. So keep that in mind. Recreationally running 5 km, 10 km, being physically active, it's good. So these people have osteoarthritis risk of 3.5%. 3.5%. Keep that in mind. So overloading also can be a risk factor. Possible. Any other risk factor you want to add?
Yeah, usually you can say genetics.
Beautiful.
So genetically also the people might get osteoarthritis. Because if we have inflammation in our body, it will change. It actually, the inflammation triggers the genes also. We have lots of genes which is causing inflammation. So if chronically I'm having inflammation, means my inflammatory producing genes also will get activated. And once I develop osteoarthritis, the bone remodeling will occur. So bone remodeling is caused by one gene. We have bone remodeling gene also. So that will also get activated. So if that my gene is converted to my generation, next generation, so definitely they'll have lots of chances to get osteoarthritis. But still, it is also preventable. If because all genes will have the potential to cause inflammation. But if you are highly active, you are having good anti-inflammatories, means again you can able to fight for that. So genetics also one of the risk factor, but we can prevent even though it is genetic.
So your mother and father plays crucial role on your health. Okay, keep your mother's.
Imagine we fell in love on the winter moonlight skies with you. I think I'll
We. Yeah. Our physical activity plays more role on your sons and daughters in future. Very good.
The biggest asset we can the biggest asset we can say for our children is not big buildings or
Exactly.
a property. Good health is the biggest thing we can say
can
for
say.
our children.
But no one accept. Fine. You want to add any more risk factor, or shall we move to the next topic?
So the female gender is more prone. I think so. It is due to some after menopause some hormonal changes, but I don't know exact what cause.
Anyone here to help? Why female genders are more?
So because after menopause, the estrogen will be less. Comparatively to priorly, it is less. So it stimulates more inflammation.
Yeah, actually, estrogen is responsible for protecting your cartilage and protecting your bone. Also, not only, but it is also responsible for bone health, and it improves calcium storage, like that. It will helps for bone health and also cartilage protection, and also it will responsible. It act as a inflammatory properties too.
So I have a question. If female have a estrogen, male doesn't have estrogen, who's taking care of cartilage then?
Actually, male have high amount of testosterone. Testosterone is responsible for maintaining.
So
the
for
cartilage
male,
health.
testosterone is responsible for maintaining the cartilage health. Female, estrogen is responsible for maintaining the cartilage health. Female tend to lose their estrogen after a certain period of their age. So they're prone to have osteoarthritis. Simple logical point. Hope you got clarity. Fine.
So actually everyone feel like if we have obesity, we'll have osteoarthritis. Predominantly we'll say because of weight bearing. If they have big body obese, then entire load will comes to knee, they'll develop osteoarthritis. But if we say it is not about weight of the person, because we have lots of bodybuilders or we have more heavyweight person also, but everyone is not having osteoarthritis. So it is not about weight that is coming to your joint. So in obesity, it's all about how much composition of fat you have. Because if you have more fat, all the fat has the tendency to create inflammation. So in obesity, that is the major reason, not only the weight that is entering into your joint.
Okay, it stimulated me one good question. So they have general attitude and understanding that overloading happening because of obesity. That is why you are getting osteoarthritis in the knee joint. Secondly, in the hip joint. But unknowingly, wrist joint also one of the more prone joint in osteoarthritis. Third most, considerably third most means wrist joint is not a weight bearing joint. Right. So how it makes sense? Is it true? Not? Where we can take it?
If you are doing weight bearing, the cartilage has to withstand that weight bearing. So cartilage and subchondral bone is playing major role to withstand that load. So if every day you are giving some abnormal weight, your muscles are not strong or your cartilage bones are not strong to protect that, it will go for damage and it will create again triggers inflammation, everything. So weight bearing is one of the reason. But we can say in knee joint definitely the load will enters into the knees because the orientation of the joint is superior inferior. So load will enters into the joint. And the same way wrist is also superior inferior orientation.
Okay.
So we have the tendency that means the wrist or cartilage has to withstand some load actually.
So usually humans will weight bear to wrist also a lot unknowingly.
Yes, of course. So it is true. Weight bearing joints has the more tendency to develop osteoarthritis.
Ankle also we can add into that.
Of course,
Mostly.
of course.
But ankle has higher risk factor. If there is more ankle sprain, high grade ankle sprain, risk is more.
Yes.
Okay.
And one more thing, shoulder osteoarthritis is very rare because in shoulder it is a high mobility joint, so we'll use the capsule more. So the demand of the capsule is very much.
And also I feel weight bearing is not against two bones.
Yes, because it
always
is-
whenever you weight bear, you pull like this, but articular cavity was
Yes.
like this, head of humerus was like not weight bearing like this. We always weight bear like this.
Yes.
So there is no impact on the articular cartilage.
Yeah, it is a side to side orientation joint. So weight bearing possibilities of weight bearing is
Medial lateral
rare.
attachment.
Yes. But hip joint is also medial lateral orientation. But hip
But
is more.
depth, there is a more depth, vertical transmission of force. Was
Yes, because our weight is transmitted through hip.
two hips comes and aligned like this.
Yes.
So central transmission. So the direction of force and deeper the hip socket plays crucial role. Even though there's medial lateral, it has a superior articular transmission of force too.
Yes, of course. So weight bearing joints has a more tendency to develop osteoarthritis, but it is preventable. But in obesity, weight is enters into the joint. That is not only the reason.
Only the reason. So my next question is: so someone come with the complaints of osteoarthritis. No, sorry, not osteoarthritis. Sorry. If someone come with the complaints of knee pain, age was more. So what are the criteria it makes the diagnosis more prone towards this is an osteoarthritis? Chances are higher. So age factor, one thing you said age. Second thing, females,
Other risk factors,
Other risk
female,
factors.
obese.
obesity,
Then their physical activity.
physical activity status,
We can see, of course.
comorbidity. These are things we can get listen to the patients, but pain ways and during the consultation assessment, what are the factors we have to keenly looking for to diagnose this is an osteoarthritis?
Pain during loading.
Pain during loading, beautiful point. Maybe the patient complains of pain during stair climbing, standing, sit to stand, loading activities. Good.
Then in early stage, because of inflammation, we might have swelling.
Okay. Also, maybe they're present with swelling.
Yes.
Swelling. Okay.
Pain
swelling
and
loading
swelling.
during weight, pain during loading, swelling,
Yes.
and any other things.
Joint stiffness.
Age is more higher, joint stiffness, reduced range of motion,
Yes.
either extension or flexion, muscle strength, less muscle mass. That is, if you the people usually have females more than 50 plus years old consulting with us with light obesity. When looking at, they look like thigh is big thigh, they have bigger thigh, but when you palpate, there's more of a fat, it's not a muscle. That is also can be the reason. So as we discussed, the period risk factor also comes into play. For example, we can say one male come with 32 year of old having any pain during the load and having good fitness, regular into activity, less chance of getting osteoarthritis. One female come with a 52 year old and having light obesity, having a comorbidity, there's a high risk of. So probability, it's not like that person doesn't have osteoarthritis, maybe very rare, 0.01% chance. Okay, and I feel one important component we missed explaining in the risk factor, suddenly it comes to my mind, is the deformities.
Yes.
Deformities by birth, congenital, right? Anyone want to add any more points on it?
So it causes abnormal joint loading, so that it may be due to,
So
it can
also
lead
comes
to
under the loading factor,
Yeah.
overloading factor, but due to abnormal loading. So when I say younger age, quickly that comes to mind. So younger age person, how can that get osteoarthritis? Maybe the abnormal loading, genetic factor can be the reason. Bow leg or knock knees. These are all the factors. Maybe the reason for it. Fine. Any other things to confirm that is an osteoarthritis?
Usually we'll do one mistake. Any patient, any old age patient came with a complaint of knee pain and they're obese means we assume them as a osteoarthritis. And we confirm with the X-ray, but X-ray doesn't show any changes. Joint space, there is no joint space narrowing like that means it is quite difficult to diagnose. So on that time we can go with inflammatory profiles, ESR,
Beautiful,
erythrocyte redimension,
So-
CRP, and
So not
other
only
exercises.
rely on X-ray, X-ray as we discussed earlier, people who do X-ray can show two different symptoms.
Yes.
So don't rely on X-ray alone because X-ray shows very severe stages changes.
Yes.
So just do the inflammatory profiling.
Yes.
Any inflammatory markers are higher. That's good, very good. What about MRI and ultrasound? Yeah, we know X-ray. We discussed Kellgren and Lawrence scale and X-ray. What about ultrasound? MRI? How it plays role on identifying the osteoarthritis?
We couldn't able to confirm the diagnosis with the help of MRI or ultrasound.
So, in
but
simply, MRI is not a useful diagnostic tool in
Yes.
osteoarthritis.
yes. So actually, it is not a confirmatory tool, but it also shows some results, like because you are having inflammation. So it shows like synovitis, joint effusion, like that. But in other conditions,
Not necessary, what I feel. You
yes,
spend
of
5,000
course.
rupees for confirming that's osteoarthritis. A lot of other information we can easily confirm. That's what I
yes,
feel.
yes. But in ultrasound, we can able to find out in the early stage because it shows inflammatory reaction symptoms like synovitis, joint effusion, like that. We can see, and it is cheaper than MRI too. So there is no need to take MRI. Simply we can go with ultrasound, but it is not necessary.
Fine. So, someone come with the complaint of osteoarthritis. So, clinical features quickly. First part is age. Second factor is comorbidities.
Factors:
Reduced physical activity.
muscle strength,
Female gender, less muscle strength, obesity, reduced range of motion,
Pain during
pain during loading. 8 factors was there. And then
no morning stiffness or stiffness less than
beautiful, no morning stiffness or stiffness is
less than 30.
less than 30 minutes. So rule out rheumatoid arthritis. Very good, very valid point. Inflammatory profiles, and then X-ray if it is needed. X-ray if it is needed. If this is okay, then just
See,
maybe
once
that.
all the clinical symptoms, features are telling it might be osteoarthritis, means we can confirm it with the X-ray, but X-ray is not only the diagnostic tool.
So osteoarthritis is basically a lifestyle disease. So when it comes to lifestyle disease, it's irreversible. It's irreversible. We can manage as best as we can. So considering that, we will talk about once we diagnose, we will talk about the management. So what could be the best possible management for osteoarthritis?
Actually, when it comes to osteoarthritis, when we ask the patient to go for walking or do the exercise, they feel that it's loading much. So the thing is, we should make them educate that something is better than nothing.
So education.
Yeah, education is play. Yeah, so we have to make them understand moving a joint little and moving a body, like in reducing the inflammatory cells in your body,
So
that
first
will help.
priority is not that to reverse osteoarthritis or
No.
protect osteoarthritis, reduce inflammation.
Yes, first
through
control
education,
it.
Explaining
Yes,
them why
yes.
it can lead to you. So maybe physically arm ergometer we can do.
Yes, of
Swimming
course.
we can do. The facility was
Aerobic
aquatic
trainings
therapy,
like
not
that.
aerobic. Cycling we can do.
Yes, of
Reduce
course.
the joint loading. Cycling you can do. So depends on the tolerance again. Fine, that's great. So first points you mentioned education. Any other point?
Other than that, any kind of physical activities like aerobic exercise, strength training, any other physical
So
form. also we
any
can
form
do.
of physical activity, including yoga or anything, helps.
We need to move our body.
You need to move your body. Here the important concept comes, na? So loading causes pain. We are again asked them to load. So as we discussed, how this contradictory? How can?
Actually, some therapists also think this. They'll also get afraid to give exercise. So they'll usually go with the passive modalities, wax therapy, TENS, everything they'll usually apply, ultrasound, like that. But actually your knee and cartilage is created to withstand the load. You have to make the joint healthy to give some load. It is actually osteoarthritis occurs because of the overuse, overload, excessive load. But adequate load is very much necessary to protect your joint.
Sedentary population have higher risk.
Yes. So we have to load the joint. We have to strengthen the muscles. We are when you give load, then only your cartilage, bone, everything will become stronger. Again and again stronger.
So loading is not bad. Even though the person has pain, education.
It is not necessary to use harmful words like joint loading only causes pain. If we use that only, the patient mentality they will think that loading will causes pain. Then
The
only
words like bone to bone erosion, wear and tear. So those words are
Words
little
are
hurting.
better.
Yeah,
Language
yeah.
speaks more than the problem.
There is a difference between joint loading and maintaining the joint health. We are maintaining the joint health.
You are maintaining the joint health.
during
Overall.
During exercise, okay.
Not
Is it enough to convince the people to change their mindset or anything more point of add? I feel it's not enough.
because it was practiced for long years.
Long
right?
years, yeah.
We can't change in a single video.
Single videos. So, okay, I will upload many videos like this. Don't worry. And also, if you want to practically learn how this loading changes, how this helps, and everything, check out our last video, exercise prescription during pain. By clicking here or after watching this video, you can check out exercise prescription during pain part 2. In that, I have explained the patient come with the comments of knee pain, how to progress exercise, regress exercise by loading, sit to stand, basically given. But now it's time to talk about 2 points we discussed. One is patient education, one is physical activity, and third point importantly, which I feel is lifestyle modification, diet modification, sleep, and everything.
Diet modification plays a major role because it what is the food we take in, it also has some anti-inflammatory effects. Vitamins, minerals, it also play an important role.
Protein also you have to take. In Indian current mentality, you should take carbohydrate only. You should not eat protein. If you eat protein, you're wrong.
Only gym goers will eat.
Protein powder is steroid. Okay, you should not take protein. You should not prescribe protein powder to your mom. Your mom will think you're putting me steroid. My kidney will get failure. That's a common understanding that people. We have to change. We'll make another video for it. Don't worry. So the current understanding, last point of discussion is what about surgery? When you prescribe surgery. So basically, the point is very clear. When the person diagnosed with osteoarthritis, I will first of all try to postpone the surgery as much as possible. Okay, but the end stage person reached beyond nothing to work with that. So absolutely conservative management is not possible at that time. What you do surgery, right?
Yes.
I also asked question. I have answered. Fine.
So the age and functional impairment of the disease plays a major role while going for surgery. So if the person is only 35 years having OA, doing surgery is not necessary. So the
But
what
lean,
kind
the
of
person is lean, it's not necessary.
necessary?
We can what are the factor to postpone surgery? You can say previous muscle activity, confident of the person. Okay, fine.
So it is not necessary to have surgery for a 35-year-old patient who is having OA because surgery. If you are doing surgery, it will only last for 10 to 12 years. The processes which we fit in.
15, almost
15 to
15
12 to
years.
15
Yeah,
years.
12 to 15 years. It depends. People has sustained 20 years also. How you're taking care again, that's plays
Yeah,
crucial
okay,
role. But if you're going for early surgery, and so many, recently I had a chance to discuss with one doctor. The doctor said, Azhar, did you see total knee replacement? Yes, sir. Did you see total knee replacement after total knee replacement? Second time total knee replacement? No. That was happening nowadays.
Oh, resurgeries.
You may going to see the people who did total knee replacement again is going to do total knee replacement in 5-10 years.
Because they have
Pre-surgery.
taken care of.
Exactly. The education, again, this is where the education plays crucial role. Again, so I will end up with this point, very valid point. The person have a grade 1 osteoarthritis. Okay, no need of surgery, you can postpone as much as possible. The person have a grade 4 osteoarthritis, severe, very severe. Try to manage little bit, consider the financial status and everything, and lifestyle changes, education should be very, very necessary, but surgery is a better option. After surgery, improve the tolerance and adherence, make them walk, stand, withstand and everything, and don't eliminate the fear from their mind. You did surgery, you have to protect your leg. You are doing surgery to improve your function, not to protect your leg. Okay, when that's grade 2 and grade 3 is highly determined by the patient previous physical activity, and we said the risk factors, how many risk factors the person has. Even the grade 2 person have all the risk factors, there is a chance of going surgery earlier. Grade 3 person doesn't have a more risk factor, lesser the risk factor, less chance of going for surgery. And also the person attitude, confidence, behavior, past experience of him, lifestyle, person's mother, father, how influenced him or her, so many things plays major role. So considering this, surgery is highly determined by the individual. It's not about osteoarthritis, it's all about the person who attached to it again.
So final question before the end. So what about the corticosteroid injection? How it helps Is it useful or how?
So actually, it is somewhat, people think like it is useful to reduce pain and everything, but actually we are again reducing the symptoms. The main reason for developing osteoarthritis is inflammation. We are not reducing that inflammation. Just simply we are maintaining pain free by putting some injection in the knees, steroid injection like that, or takes the sometimes they'll take the chondroprotective supplements to protect the cartilage. So even though you are taking some supplements to protect the cartilage, you are not correcting the root cause, which is causing damage to the cartilage. So you are trying to protect, but you are not reducing the degradation, the cause. So again and again, it will end up with the progression. So it is all our symptomatic management. So the corticosteroid injection, the chondroprotecting agent, somewhat helpful, but it won't help you for the long life.
Long life. So
So
during
maybe
that,
you can take in short term. There will be some effects, right? In short term, if after injection, there will be pain free. In that time, you go for exercise, right?
no, if you don't have pain, patient won't respond to that. If you have pain, the people will listen whatever you say. If the person doesn't have pain, pain is the medium of giving. So, for example, someone in front of you saying you should believe whatever the person say. You should confuse, and you are going to shake your head means you should have pain. If you don't have pain, they won't shake your head. Priority changes. Again, this is what if there is so much of pain, your pain is your first priority. As much as your pain is coming reducing, so that's why gradually reduce the pain. Don't reduce the pain immediately. As I always don't focus on the symptoms too much. As I always say, so that helps to handle the patient through mindset. So the realistic expectation comes from the patient mind. Slowly they feel 20% improvement after 3 weeks of sit to stand, 40% improvement of 5 weeks later. 10 weeks of rehabilitation helps them to pain-free climbing the stairs, 10 steps at least. That creates strong attitude towards physical activity. That creates strong positive mind towards the exercise. So next time they have pain, the first thing comes to their mind, I'm not doing exercise for past couple of days. That's maybe the reason. So always the exercise could be packed in a pill. It would be single most widely prescribed medicine in the nation. Everyone knows who can prescribe exercise. We are physiotherapists. We are not prescribing exercise to the patients. We only focusing on the pain management, symptomatic management. That is where our profession also getting affected. Quality of the profession also getting affected. I'm not saying that is wrong, but I learn more, understand more. That is the reason we are making this kind of podcast, a discussion with our team. We are putting a lot of effort behind it to read, discuss, and everything. So that's where it comes from. So you want to connect with us to learn more about a different condition, and you want to improve clinical practice. We are available through EP Classroom to teach you in online, always in every day, morning or evening. Every month we are coming up with a new course to teach the people to improve the physiotherapy practice. What we know, we're not saying we are the only people are practicing well. There are so many others are doing good job, but we are trying to do as best as we can from our side. So if you're interested, you can also join with us through EP Classroom or online class, everything. So this month we're also taking osteoarthritis. Okay, that maybe while uploading this video, the class could have been started. So we wait for one more month, January batch you can join. So if anyone asks or request, we'll add that contact number also in that comment section. And finally, anyone want to say anything?
Yeah, I would like to add on a point. I would like to add on a point on the rehabilitation process. Like osteoarthritis haven't developed in a day, so it took a long to develop.
Exactly.
So
Beauty.
don't expect instant cure
Really,
for it.
it developed 30 years, 40 years of your bad lifestyle. Biggest reason. So don't expect quick improvement.
Yeah,
Okay.
previous generation.
Okay, I think we are shooting this video after getting so much of hungry. Lunchtime is crossed. Patients are going to come to our clinic within 10 minutes. We have a lot less than 10 minutes to eat. So considering that reason, so we are ending here. So anything which we missed, we might have missed something. We might have questions, some other questions. You can ask in the comment section. As always says, happy learning. See you in the next video. Bye.